Good evening, everyone. Welcome to the Northeast South Dakota AHEC and the South Dakota EMS Association District 4's monthly webinars. We are very excited to have Corolla Lauck talk a little bit about navigating pediatric resources and care. If you have any questions, feel free to put them in the chat throughout the education, and we will try to get those answered for you as much as possible. Once again, if you haven't registered on the image trend for this class, please do, or send me your license number and I can get that taken care of for you. Without any further ado, I'll pass it over to Corolla.
All righty, hang on just a little minute here. Don't mess with the good thing, right? That's the whole bottom line. How many folks do we have on?
It looks like we have 37.
37 folks. All right. Good evening, folks. I'm super excited to be here with you. Also super excited that we don't have below zero temperatures. With that, we've had a little bit of ice this morning, a lot of black ice and things, but I wanted to visit with you, if we could, a little bit about navigating pediatric resources and care. Michaela, can I ask you, do they have the ability to participate or not?
Mute and unmute themselves? Yes, they
Yes.
can.
Okay. 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 I just wanted to double check and see if there was a possibility that they were able to do that. So I'm glad to be here, folks. I'm the program director for South Dakota EMS for Children. And by being the program director, I've been here for 10 years. Prior to myself being here, Dave Bohr was the program director. And as Dave was the program director, we he ran it, I think, I want to say about 23, 25 years. He worked along with Amy Marsh. She was his partner in crime, if you will. And then Jamie Bartell is my right-hand gal. And she's an amazing, amazing partner to have in this. So I'm going to kind of flip this around a little bit because I want to know what you folks know about us. So we're going to talk about a few things. The first thing we're going to do is we're going to talk about is our learning objectives. And with our learning objectives, we want to make sure that we develop an understanding. And, oh, let me see, Michaela, did you get the learning objectives? Is that popping up?
It looks like we're still on the home screen or the
Okay. All right, we need to, let's do this from the beginning. I don't know where I lost it. Shoot.
And if you go to your screen and click the next button, you should be able to.
Next. I think I got to be on this next screen here. Okay, so here we go, folks. I apologize. To develop our learning objectives, we want to make sure that you understand the unique challenges and considerations when you provide emergency care to pediatric patients. And we want to showcase the contributions and support provided by South Dakota EMS for Children to enhance the quality of pediatric care. We also want to identify and explore the array of resources and programs that we have available to you that are tailored for specifically for pediatric emergencies, including guidelines, protocols, and tools. And then also, I hope that you have a better understanding of what you as EMS providers in the community can do in engagement, promoting awareness and preparedness for pediatric emergencies. So, and with that, I'm going to move you on. I'm going to switch back in between here. So we talk about kids, and we can talk about kids all day long, and I can give you an anatomy and a history of a lot of different things. I did really honestly I lost my ability to look at my notes. I don't know where my notes went, Michaela, but I can talk to y'all. I'm sorry.
I was gonna say, if you hover over kind of the bottom of your screen, you should be able to see the different tabs open for presentation or PowerPoint. You should be able to pop back up.
Um, hmm. Well, we're gonna wing it here, because I don't want to waste your folks' time. And I do apologize. We can talk about anatomy, we can talk about physiology, we can talk about age, we can talk about the mentality, we can talk about so many different things when we're talking about kids. I'm going to be preaching to the choir. I know that's something that we don't do on a regular basis. We don't run a lot of pediatric calls on a regular basis. But what I do want to share with you is that we have a number of resources available. We have things that are out there, and I am just going to have to stand by for just a minute. I'm going to have to find my. We are very rural and frontier, and I think that's for you folks. I want to ensure that you realize that we are from the Midwest, and that with that, the process of being Midwesterners, we know we are rural frontier, primarily rural frontier. And with the rural frontier lifestyle that we live with, what is it, 33 and 34 rural frontier counties, and then only 2 counties make up the 66 counties, and they are on opposite sides of the states. So we are in Sioux Falls, and then we look into Rapid City as our largest area there. So the population of South Dakota right now, the estimated population for as of July 2023, anybody have any idea where we are for our population? I'm going to pop back on. So we're a population, we're over 919,000 people in the state of South Dakota. What percentage do you think of that is pediatrics? So when we're looking at pediatrics, we're looking at birth to the age of 18. What percentage of this population is pediatric patient or pediatrics?
I'm gonna guess 40%.
40%? You're close. It's about 24% is where we're sitting with our population with children in the process of that. That also relates to you in the process when we look at your community as well. So if you're a community of 800, you can figure about 25% of your population is pediatrics. Then I'm going to ask you to look a little bit further into it. As you look into it further, how many of those kids that you have in your community are special needs? So I think we know, or you know, your communities better than I know your communities. We know who how many children that we may have with autism spectrum disorder. We may know the number of children that do have special, or they're fragile and they have special health care needs, including tracheostomies and things like that. The number of children under the age of 5, we're looking at about 6.5%. And then again, under the age of 18, 24% is where we are. Kind of an interesting number. Of our kids, about under the age of 18, about 6% of our kids are, we outlive 6% more than what the 65 and older population actually is. So with that, we're going to move you to the next one. So again, we are the Midwesterners, and with being Western folks, and you have that on the screen here. I don't know, I kind of love this video. Some people forget that, you know, the rural frontier world, that we're out here. Let's see if this will play for you. Whoops. Sorry. Lord have mercy. Can you hear that?
Yes, it
Okay.
is kind of quiet though. So you might need to,
Turn my volume up. Oh, it wants to stop everything when you're doing that. I'm not going to go any further with that, folks. The music's actually kind of sad. I think it's more about the video and having an understanding of where we are in the state of South Dakota or even in the Midwest. And being in the Midwest, we don't mess around with buffalo. We don't cow tip. My son-in-law, when he first started dating my daughter, had the idea that he was going to go out and tip cows and had absolutely no idea where he was from. He's a city boy, and it is what it is. So when we look at, I got to stay over one side and go with the challenges. When we look at the challenge, tell me about the challenges that you folks see in your world as EMS providers. What's the challenges with your kids?
Distance to qualified care.
Oh my goodness, distance to qualified care. Who said that?
Dave.
Dave, where are you?
McPherson County.
McPherson County. So you're looking, so how far are you from the hospital?
We have a hospital in Eureka.
Yep. How far, so how far, the area that you cover, how far are you away from getting somebody to Eureka?
We have almost 1,200 square miles in McPherson County that we care for.
1,200 square miles?
So Eureka to Aberdeen is 75 miles one way. To Mobridge, it's 60 one way.
And are you doing, so critical access hospital, and with the critical access hospital, are you transporting folks from a critical access hospital and going into Aberdeen that can provide more care as well?
That would be fairly common, yes.
Okay, very good. Anybody else? Who has the longest distance even to a critical access hospital?
I don't have a long distance, but I have language barriers.
Oh, tell us about your language barriers. That's a fantastic challenge to hear about.
We have a lot of Spanish speaking people moving into the community, and then also Hutterite people. So then it's German.
German.
And yep, and kids don't learn English until like the 8th grade in the Hutterite community.
And how are you navigating that challenge, Nicole?
Apps apps on our phones really is our biggest thing right now, and the Avell in the actual ambulance. But apps on scene is the best thing right now, but it's not fabulous.
So no, the apps are kind of difficult to navigate. And then if I can ask with Avell, what number of you folks, and what is there, 38 of you folks, 47 of you folks on, how many of you have the telehealth in your trucks?
We have it up in the Condi area.
And then if you needed the ability to cross over that language barrier, do they have the capability of tuning you into either someone who speaks the language, an interpreter?
Yes, they get us an interpreter as soon as we ask for one. They get one on there.
Fantastic. I'm glad to hear it. Okay. Other challenges that you folks have out there. So we talked about distance, we talked about language barriers, other things that we look at. Those can't be the only two challenges.
Everybody's volunteer, so not everybody's available.
Volunteer, not everyone's available. We have a small number of resources. in our volunteers. Some of our services are running maybe 5 or 6 people. Some of our services are on the brink. Money is a challenge. There's all kinds of challenges out there. And even the challenge of when we look at education. So when we look at education, there's lots of education out there. I think one of the bigger challenges that I see that folks are having is we have a plethora of education that's available to us, but with the plethora of education that is available to us, we're not using our skills. So we don't practice our skills. Some folks are, but it's not like back in the old day, 10, 15 years ago, or even 10 years ago, where we were out there and we were pulling out backboards and we were pulling out Broslo tapes and we were pulling all of these things out and actually using those resources. So we have a loss of muscle memory, if you will, when we're in the process of that. Anything else that we can look at that you folks are having as challenges out there?
I guess to kind of go with the volunteer thing is we don't have ALS. We're just BLS. So if somebody's in critical, they're not getting the resources they need as fast as they need it necessarily.
Rose, where are you?
I'm in Condi.
Yep, we're in Condi.
Yeah.
Do you ever call for flight?
I'm brand new, so I know we have,
Okay.
but I haven't since I've been on.
You haven't had the opportunity to do that. Okay, so here's one of the challenges is we know that kids, I'm going to call them unicorns for lack of better terms. When do you look at this picture, what do you see?
A happy, perfect life.
Happy, perfect life.
Mama guarding her children.
Mom guarding her children. Unicorns and rainbows and flowers and everything that is all perfect in there. So if I spin this a little bit for you, now I take the mom and the child, if you will, or so the mare and the foal. Now I turn that into a pediatric patient, let's say maybe a 3-year-old, and now I turn it into an 18-year-old. Now what's your caption? So there you go. It's your unicorns. Our kids are unicorns. So we have such a large age range when we're going birth to 18 years of age. In your communities, have you had anybody that falls under an age group that you would not consider pediatric? I know that's kind of a weird question. So when I was out in North Carolina and we were with Duke, we had a young gentleman that had a disease called Pompeii's disease. And he went to the hospital whenever we transported him, and he went to the pediatric unit, and he was 32 years old. So they followed him all the way through the course of his disease so that they could learn more about the process. And his mortality rate for his age, he far exceeded it. The care that this young man got, not only from his mom, but the care that he had from his full-time nurse provider was absolutely amazing. So sometimes you may see in your own community that you may, even given the, we have Sanford basically is our children's hospital, but our larger hospitals are able to take care of pediatrics. You may see somebody that has, that is older and that's actually falling into that group. Again, we talk about birth to age 18. We got a 2-year-old going on 12, going on the 25. I've got a number of grandchildren and a 3-year-old with an attitude and a 5-year-old with a big attitude, big low voice, and goes from there. The communication barriers, I think those are very interesting. So not only do we have language barrier, like Nicole said, but we have communication. So communicating with a 3-year-old, communicating with a 2-year-old, figuring out what's going on with a 6-month-old. When mom calls and she says, hey, something's not right, my baby's sick, and it's just not right. And to you, it appears like the baby is fine. What do you do in that instance?
I listen to mom. She knows her child best.
Yep, mom knows best. So mom knows best. So when you look at that and she's telling you that something's not just right. And there's a period of time where when these little ones are out there and maybe you're, do you guys put EKG patches on when you're out there? Let's say mom says, baby won't take a bottle. He had projectile vomiting. We'll give you a 3-month-old. So pretty well adjusted and everything. Projectile vomiting, normal diapers, and we have kind of a kid that's a little more lethargic. He just doesn't look right. Would you put EKG patches on this little guy? What would your assessment be?
The quality of care never changes. You still have to do what you have to do. You can cover the child up with a blanket, do some different things to distract them, but you still got to be able to do your job.
So don't change anything, folks. Just because they're little ones, don't change anything. If you're going to do the same for an adult that you're going to do for a pediatric patient, either get your peds pads out, so your EKG pads out, get them out, or if you have pediatric pads, get them out and put those on a kid, especially when we're looking at projectile vomiting. Maybe this kid is red-faced. Maybe this kid has a history of WPW. Do you know what WPW is?
Wolf Parkinson's White syndrome.
Right, Wolf Parkinson's White. So what would you expect that heart rate to be?
Possibly high.
Oh, super high. So probably over 150, depending on the age of the kid. You could get up into the 240s. You can get up into the 300s and the 400s for a heart rate for those kids. You want to make sure that you're listening to breath sounds. Listening to those breath sounds are vitally important. We want to make sure that they're actually moving air, that there's not fluid starting in their lungs. And then even for those of you who are ALS, you have to get a good history, and getting a good history is so vitally important, because if you give a fluid bolus, you're going to flood those kids. So that's an SVT versus a febrile kid. A lot of the heart conditions come on very, very quickly. When we look at the colds and RSV and things like that, they kind of gradually come on. So always kind of pay attention to what you got going on, but don't treat them any different. Get a blood pressure if you can get a blood pressure on the lower leg. We know that blood pressures for our kids sometimes is difficult. When I talk about a 3-year-old or a 2-year-old with that, do it on the thigh. But if you have a low blood pressure, folks, on a pediatric patient, and use your resources. I don't expect you to remember all of the different blood pressure rates for kids due to the fact of they're so variable. If you've got a low blood pressure in a child, that's a very ominous sign. You want help as fast as you can get that help, even if you have to do transfer where you're meeting an ALS unit on the road and you're actually transferring the kid, or they're hopping into the back of your unit, or you have to call flight team or something on that order. It's really super vitally important. Our kids are struggling to grow. So when I'm talking about struggling to grow, they have peer pressure. So we look at all of those peer pressures, and they also have attitudes, right? So some of those kids can be really difficult to communicate with. You got a 12-year-old girl who is just snapping back at you every time you turn around and you ask her any kind of a question. What's your thought process there?
That could go two ways. Either that's her normal, or she is out of sorts and you have to figure out why.
Yep. So I think one of the primary questions we have to ask ourselves, and it's really, a lot of us have been in this for a long time. There are a few of you that are newer, but it's still one of those things that we need to keep in mind. It's not what's wrong with this kid. It's what happened to this kid. So now I take that 12-year-old and I tell you this 12-year-old is snapping at you, and she's snapping. She's not going to answer your questions. She's not going to look at you. She's not going to do any of those things. Maybe dad's in the back. Maybe somebody's in the back. If you can get her by herself and actually have a conversation with her, maybe there's something else going on. Maybe she's being trafficked. Maybe she's going through some kind of abuse and things like that. So it's not necessarily what's wrong with this kid when they're acting behavioral, that mental behavioral health. It's what happened to this kid that would make them act that way. So always kind of keep that in the back of your mind of what's happened to that kid, regardless if they're 3, regardless if they're 15 or 18 years old. Just kind of pay attention to where those kids are coming from. And again, a lot of peer pressure, bullying. We can take bullying into that consideration as well. My granddaughter's going to be 10 coming up here in February, and right now she is being bullied like nobody's business. So we have conversations on how to handle that. And I've given her, and I think her mom's probably given her permission. You don't throw the first punch, but you sure do throw the second punch, and kind of put it out there. When we look at the behavioral and mental health, we also need to pay attention. We actually have, if any of you had to transport a child to mental health or behavioral health, we don't have much for services available. Thank heavens for Avera and the growth of Avera and the growth that we've seen down in Yankton, so that we can have more of our kids go places. We've also seen that when we're transporting patients from one hospital to another hospital, to a higher hospital, it's hard to get them there. Sometimes you're keeping patients for a long period of time. And then when you do finally have that transport period, that's important to note that that child's probably been in the hospital for longer periods of time, and maybe they're upset, maybe the parents are upset. So you're dealing with a whole lot of different personalities. You're dealing with a lot of concerns with you as you're working with these kids. So when we talk about the challenges, we talk about pediatric calls. And here's one of the things that I hear kind of on a regular basis is, but we don't run pediatric calls. And we don't run pediatric calls. And I want to know why. Why do you tell me you don't run pediatric calls? Why would you say
Called for them.
what's that?
We don't get called for them. It's maybe like a once a year thing.
Yep, it's a once a year thing. So Bethany, how where you're located, and how many what's your population?
I live in Murdo. The population of the whole county is about 900 or so.
About 900. So we don't see those kids very often. But what we are seeing is we are seeing an increase in the number of pediatric patients that we do transport. And those pediatric calls, you have to keep in mind, birth to the age of 18. So when we look at, we're taking a football player off the field and he's 16 years old, we don't tend to think of them as a pediatric call when in fact they are a pediatric call. Giving you an idea of what those numbers actually look like in 2021. I think last year we got hit pretty hard. In 2022, we got hit very hard. I think that was our RSV season with flu season. We're not quite done with that yet for 2024. Normally our numbers were running, in years prior, we were running about 7,500 calls is where we were running those calls. About 10% of the calls that are out there for pediatrics, those 10% of those calls you're going to receive. And if you're a small community, your 10% may look like 0.01%. So it's kind of one of those things to kind of keep in mind, but that becomes about preparedness, right? So preparedness is one of those things that we need to keep at the forefront of our thought processes. And I kind of move back and forth here just a little bit, folks. I apologize. So how do you feel when 911 dispatches you to a 3-year-old, and why? How do you feel when 911 dispatches you to a vehicle rollover with ejection and for teenagers ages 14 through 16? What's your initial response? How are you? What's your heart rate doing right now? I'm not going to give you a scenario, or maybe I am.
It's racing like crazy, and you hope you have extra help.
It's racing like crazy. You hope that you have extra help. So already when you hear that call that's coming out, you start racing. Your mind starts thinking about what you need to do, where you're going to be, what resources do you have, what resources do you have, what resources will you need. All of those things kind of go through your mind. And then coming from small communities, even though I'm in Sioux Falls, folks, I am rural frontier. I'm coming from Nebraska, and Nebraska, our town was about 800 people is what we had. We did have pediatric calls. Our closest hospital was either Norfolk or Yankton. Traveling probably 75 plus miles per hour. We were looking at 60 minutes, maybe 45 minutes, depending on where we were on in the county. So I get where you're coming from. I've also worked metropolitan, you know, when you're over 240, 250,000 people and you're going to the hospital. So I get where you're coming from that. The reason I kind of put this ambulance on there, and I'm thinking most of us, I've never driven a unit like this, although it would be fun to drive it, but we look at where we've come from. So we have the resources. Here, it was basically you pop them in the back and you go. Now, when we look at pediatric patients or patients in general, we want to be doing something with them. Diesel treatment is definitely not the treatment that we need to be putting out there. We actually need to take the time and treat that patient. So when I referred to the 6-month-old or the 3-month-old, are you taking time to put on the pediatric patches? And now what you assumed was a child that was just cranky. Now you have a heart rate of 280 beats per minute. You know something's going on. That's not normal for a pediatric patient. So treat them the way you are. You have the technology. You have newer ambulances, or you have new life packs. You have your resources from Avail. You have your resources. You have a number of resources, and you have a number of resources that actually came from South Dakota EMS for Children. I don't know if you folks know, but back in the day when South Dakota EMS for Children actually started, we actually supplied all of our ambulance services with a pediatric BLS kit. And when you look at, I think they did car seats back in the day. And if any of you have a car seat, or it was the blow up yellow car seat, I think one of the services had one, and toss that. There is the finger pincher. It's the blue one, I think, is the color of it. And you kind of have to pull the sides up and you kind of sit it up and whatnot. Toss that one as well. It will pinch your fingers to no end. It's very difficult to figure out. And we're supplying you with resources. So we're supplying you with pediatric safe transport devices. Here's a little bit of a deal on my part. And part of my deal on my part is I'm offering you folks something. I'm going to offer it once. I'm going to offer it twice. And maybe I'm going to offer it 3 times. If you're not answering your email, or you're not reaching out to me, and you're not jumping in on those kits, I'm going to move on, guys. So pediatric safe transport devices, stethoscopes, and all those things that I have resources for, or funding for, please reach out. They're there for a reason. Carter kits, I've got a whole pile of Carter kits that are available, and was hoping that we were actually going to be able to get more Carter kits out there. Do you guys know what Carter kits are?
Yes, I love mine.
Kelsey, you got
Yeah,
Carter
I
kits?
did the training.
Yep, you did the training. You've got your Carter kits. Kelsey, are you from Timberlake?
Eureka.
Eureka? So, oh, yeah, oh, yes, I know who you are.
I just did the
With that, the
training.
Carter kits. Go ahead, Patty. Did you get yours?
Yep, I did my training tonight.
Oh, fantastic. So you got your training done tonight.
Yep,
Your
got my
seats.
kits.
Yes, ma'am. Go ahead.
I got the kits too.
And you have the kits as well. We're seeing some really great things. The Carter kits are available to our EMS agencies. We're going to do a rollout again one more time for the Carter kits. Carter kits are for specifically for children that fall on the autism spectrum disorder, but you need to think outside the box. So when we look at a child or a person who is in a crisis, i.e. maybe a car wreck or a fire and they've been pulled out of a fire, or there's a whole number of scenarios, or you have a kid who's in school and something's changed, or somebody's been bullied, or any of those things, thinking outside the box. I'll tell you where the first Carter kit was used. Elizabeth Verhey from Spearfish, she had a young lady that she transported. It was a behavioral health incident. She gave that child, 14 years old, I think she gave that child a fidget toy. And then we had a 27-year-old, we had a 93-year-old, and then most recently we've had a 27-week adult female who is on the autism spectrum disorder and blood sugar issues and things like that. And with her blood sugar issues, she had her head noise canceling headphones on. They got her in the back of the ambulance and she lost it with the lights. They put the sunglasses or the light diffusing sunglasses, I'm going to call them sunglasses because that's what they are. They gave her a fidget toy. She was able to pick out a fidget toy. They were able to get a blood sugar. They were able to get a blood pressure. They were able to Doppler her. From point A to point B, they were able to get everything that they needed done before they got to the hospital. They transferred her to the hospital. She was still calm, cool, and collected. And I just talked to the gentleman who actually ran that call today. He ran into her with a brand new baby. So she's got her brand new baby with her. And she recognized him and she was having the time of her life, but she recognized him and it was a real thing of appreciation. So think outside the box when you're using the resources that we are providing you. Remember, I look at it as birth to the age of 18 years of age. I look at that, you know, we have a 16-year-old who's playing football and with the 16-year-old playing football, that kid is maybe 186 foot tall, or maybe he's 220 and he's 6'4". Use your pediatric equipment. Don't be afraid to use your pediatric equipment because we make sure that you have several different bag valve masks that fit different age ranges and stuff like that. Let's see, what else do I have here? I don't think I have anything else on that one. So with the critical access hospitals, somebody said critical access hospitals, and we're so far away from a critical access hospital. I think it's important to know with your critical access hospitals, again, we have 66 counties, we're rural frontier, and my focus is really honestly rural frontier. I have a true passion for rural frontier. A lot of our resources are in the bigger cities, in the bigger towns. Paid services is another thing that they have a plethora of resources as well. It's where we need to be able to stabilize those kids until we can get further help. That's where I really look at that it's super, super important to have the additional help. When we look at our tribes, we have 9 federally recognized tribes. I don't know if some of you folks are watching Kelloland or have the ability to watch Kelloland. They're doing a big segment on the reservation in Pine Ridge and the violence that they're having down there and the ability to for police officers and not enough police officers to basically start taking care of that violence. And I'm actually working with one of the folks down there. We've already started a process and then to make sure that we can get some resources down to those folks. With that, our critical access hospitals, for it to be a critical access hospital, it needs to be open 24/7. It's typically in a rural location that's serving a population under 50,000.
Corolla, it does look like there's a couple questions in the chat.
Well, I think I was going to pop over to that and kind of take a look. Okay. Hi, Bob. How are you? Poor community was what we were looking. Using EMS as an inappropriate resource sometimes. That's a challenge. Megan, tell me about that challenge. Why would somebody use an EMS as an inappropriate resource? Or if somebody else wants to pop in with that, that's perfectly fine with me too.
Sorry, I just walked away from my phone. Can you hear me?
Yeah, I can.
Well, we just have that was for when some of the challenges. We have a poor community and a community that lives a lot on Medicaid. So those that can't necessarily get to the hospital for the simpler non-critical reasons, well, we get sometimes utilized as a taxi service. So we get taken out of service, so to speak, for less critical things to do, and which really deters people from wanting to be part of our service because they see those kinds of things happening in the community and they don't think it's worth it. So
is that happening to anybody else?
Corolla, this is Elizabeth from Spearfish. So we had an interesting one where mom actually got medical power of attorney, even though her daughter's 18. And it's one of those that when they have their differences or they have a fight, sometimes she'll call EMS as kind of, I don't know if fail safe's not even the right word, just maybe as a threat or as a backup when it's really something they can handle. It's not a situation where it's like a kid with a special needs, is over, is overruly. It's she uses us as kind of a tool to rein her kid in when it's at the level where she could do it more appropriately. She just doesn't want to deal with it.
She's probably got fatigue. So parental fatigue, we can look at compassion fatigue. We can look at all of those things. Would your police department be a better service for that than you? I mean, I know you're probably going to go in and do your initial assessment. I'm just throwing the question out there.
Yeah, and that's basically how we've handled it. When it became on repeat, it was something that it changed from an EMS call to now more law enforcement, unless there's a readily identifiable need or they get there and concerned that there's a medical need.
When I was working Metropolitan, there was oftentimes you would take a patient from point A to point B. So you took them to the hospital. Before you got your paperwork done in the hospital, you met that guy basically walking up the street and he was already discharged even before. So you knew they were using you for a taxi ride. It was closer to downtown Durham at the time. We also had the capability of 1022ing, and what that meant for us was that we did not have to take a patient to the hospital if we felt that they did not need that. I think that's kind of gone away with all of the politics and documentation and things like that. But the goal was for that particular patient, if you we're getting ready to 1022 a patient, you needed to do a really great physical assessment and document your physical assessment and all your findings, so the pertinence and the negatives with that documentation. And then it wasn't the goal just to leave that person there. The goal was to find them an alternative ride to the hospital. So, do you have a family member? Do you have somebody, a church member? Do you have, our goal was to find a way for those folks to get to a hospital. And unfortunately, you're finding that, but I think that's something that, Megan, you might want to consider addressing in your community. And how do you address that in your community? And is there a protocol that you might have that discussion with your medical director? Wolf, Parkinson's, White, we talked about evaluated. Parents are more likely to transport the child themselves, most likely. Yep, if they're getting ready to go to a critical access hospital, about 20% of those hospitals at the critical access level, those families are going directly to the critical access hospital. They're waylaying, an ambulance service. They're not waiting. They're going to get their kid from point A to point B. Is where they're actually looking at it. Let me take a look at it here as well. How can we apply for a Carter kit? We'll talk about that in just a little bit, Lynn. Lynn, where are you from?
Dismet.
Dismet? Okay.
Dismet? Okay.
Dismet?
Carter kits, but
who's your pediatric champion up there?
Yes, I wouldn't actually have a name for that.
All right, so we're going to talk about that just a little bit later. So if you got any other questions, I think we got them all answered here. When we talk about challenges, and as I'm talking about challenges with you folks, when we look at the challenges that are out there, there are a number of challenges that you can face, but there's no challenge that's more challenging than the challenge to improve yourself. I can give you the resources. I can give you the education. I can provide you with a skills resource. But what I can't do for you folks is I can't give you the dedication. I can't provide you the passion. I can't provide you the focus to maybe focus more on pediatrics and taking care of kids and making yourself more comfortable and confident in taking care of kids. It should be at the top of your priority list. We take care of, and we do a good job taking care of our adult patients, our geriatric patients. We do a very, very good job of taking care of those folks. But we get so scared when we're taking care of a pediatric patient. The anxiety level goes up. All of that goes up. The difference between them, really, honestly, if we really keep it super, super simple, even with the ALS folks, is that we're weighing in kilograms, so the kilograms and and treating an adult. Don't get too far in the weeds. I think we get too far in the weeds because we start thinking about, you know, the future of the kids. We think about so many different things. Focus on what you have to do and then deal with it later. But you need to be prepared. That's where you need to challenge yourself, challenge your group to become better at and more confident in taking care of your pediatric patient.
I think that a big challenge with me with pediatric kids is they decline quickly. I mean, once they start declining, it's an emergency now. I mean, there's not a lot, they don't have a lot of reserve, you know. I think that's what scares me about responding to a child.
Okay. Lynn, again, we're going to talk about the Carter kits just a little bit later. I have the Carter kits. It's something that you don't have to pay for. I have Carter kits. I have funding for additional Carter kits. So you're going to do that actually through me, but thanks for putting that out there. What Patty basically supplied you is an area where you can actually start the training ahead of time and then go from there. So we can visit about that, but you are correct. Kids decline very, very quickly. The whole bottom line is just we need to be able to recognize that what's normal and what's not normal with those kids. We can also talk about practice makes perfect. What's your thoughts on that?
The response I was always taught was perfect practice makes perfect. And there really isn't much as perfect practice.
Oh, I love the perfect practice. I like the way that you flip that because mine is practice makes perfect. It's not true. We are imperfect human beings. There's human error. It's going to happen on a regular time. I kind of switch mine around just a little bit different than yours. Practice makes permanent. So when I look at practice makes permanent, the more you practice something like putting on the Lucas device and that you're very skilled in putting on the Lucas device, that you know that Lucas device well enough that that 8-year-old kid that you have, is he big enough to have a Lucas device on him? If you're putting your EKG patches on, can you do a 12 lead on a pediatric patient? How good are you doing at doing a 12 lead on an adult? How quickly can you get a 12 lead done on an adult versus a child if you feel like it is something that you need with a child? Bag valve mask, one of the hardest things to do. I think bag valve masking is the most difficult task that there is to do out there for a patient who has a respiratory drive. It's really, really difficult to time yourself and to get that amount of ventilation in there so that they're being ventilated appropriately. And we know with kids that if you're not, if their airway's not secure and it's a respiratory issue, they're going to really dump very, very quickly. And now you're going to end up with a cardiac issue and it's cardio. CPR is going to be in progress and it's basically going to be a cardiac failure in the whole 9 yards. Again, I can provide you with the education, the resources, and the skills, but it really becomes about you folks jumping in and doing it. We're getting ready to go up to Elkton in March, and Elkton is going to, they have a strong focus this go around on pediatric patients and pediatrics in general. A lot of it will be tied in with some of the adult, but that's what their focus on their refresher is actually going to be. So I am going to ask you a couple of questions. So I want you to tell me what EMSC does. I want to know what you know about EMSC. So what do you know about South Dakota EMSC? First question I'm going to ask you is, how old is the EMS for Children program? And when was it started? Take a stab at it.
35 years ago.
35 years ago, you're close, 40 years ago. So it was actually started in 1984, 1985. That's when they really started rolling with a lot of different things. How many years have we been in the state of South Dakota? So what was the year of inception for EMS for Children, South Dakota EMS for Children? When did Dave start this? So it was Dave and Dr. Carl. 1993. So we actually celebrated a birthday last year, and I realized it when I went through this here because we're so busy in the office. What do we do? What does South Dakota EMS for Children do?
give us the tools to help treat patients, pediatric patients.
Okay, all right. Anybody else? Tough question. Actually, it is a really tough question because we are so versatile in our office and we do a lot. Ask me any questions. What kind of questions do you have? What do you want to know about what EMS for Children does? So Lynn, you were wondering where do we get the Carter kits? We've started a program a number of times with the Carter kits, push them out. The reason, and I'm actually going to go into the Carter kits for right now. So the reason we did the Carter kits is we have a focus on the special needs of patients that we have out there. Autism is one of the higher numbers that we actually see for special needs for those kids. The Carter kits, actually, if you get back into the way that they were developed, it was a couple of folks basically golfing, maybe having a couple of drinks, and they start writing down on a napkin. Carter kits are named after Carter, whose dad is a detective in Michigan. And he wanted to ensure that somebody did not have the wrong idea of a child who was reacting in a certain way, either if they were stemming or some kind of way that they were not going to be cuffed and abrasively taken care of versus it's not what's wrong with that kid, it's what happened to that kid or what diagnosis that kid has. So when I do the Carter kits, even though I purchased them, like Patty just recently went through, and a number of you that do have Carter kits, I have you go through the course. One, it's being taught by a fantastic group of the Carter kit team. The other part of that is that registers that kit to you. So that Carter kit gets registered to you. And as it gets registered to you, then they have a replacement program. So if they were all registered under my name, you're not going to be able to get a replacement item. So for example, the gentleman who had the pregnant female and used the sunglasses, basically, I'm going to throw it out there, and the fidget toy, he was able to get a replacement or apply for a replacement for the sunglasses. And those are the two big items, is the noise canceling headphones. We did not go with the weighted blankets, and I can tell you the reason we didn't go with the weighted blankets. One is keeping them clean. I don't believe we should take something away from someone that's given them comfort. And that was back in the day, 2 years ago, I think, when Target came out and Walmart, and they had weighted blankets and we had 2 deaths from weighted blankets. So I didn't even want to go into that process of that. So who does South Dakota EMS for Children fall under? What program do we fall under? A lot of you, I'm guessing, believe that we are a Sanford program. Am I correct or not?
I guess I always thought you were standalone.
Standalone. We actually are standalone. So we are standalone. I'll give you a little explanation. If you look at this map, and there's actually a better map, I think there's only 7 or 8 of us that are actually within a teaching hospital. So in order to receive a HRSA EMSC grant, you either need to be with the Department of Health or you need to be with a teaching hospital. So there's Texas, there's myself, Florida, New Mexico, there's a smattering of us. So we're a statewide program. We're not a Sioux Falls program. We're a statewide program. I fall under the Sanford School of Medicine. Dr. Timmerman is my boss, and then my finance gal is super amazing, and she does things with this as well. How many programs or how many EMS partnerships or EMS for Children partnerships do you think that there are across the United States? There's 57. So right now there is 57. There used to be 58, and we covered the states, we covered the territories, and we covered the jurisdictions. So when we get into Hawaii, we get into Puerto Rico, the Virgin Islands, we get into Guam. We're everywhere is basically where we are when we look at that. Again, statewide program, our goal is to make sure that the resources are statewide versus focused. I can tell you, and I will tell you very frankly, the number of people that actually participate in our programs are usually West River folks. I have West River folks, and now we're seeing a little bit more from you folks up in the northern region, but most of the western side of the state really participates in the pediatric programs that we have available. So with that, just to kind of give you a little bit of an idea of what EMS for Children actually is, we have performance measures, and I'm going to give you the performance measures right now, and I'm not going to bore you with them really quick like this. So my job is basically to work out with the EDs. So one of the things that we do is we are supposed to be creating a recognition program for the ED. We want to make sure that we have pediatric emergency care coordinators. I would say across the state of South Dakota, with our 58 plus hospitals that we have, I would say we were probably maybe 25 to maybe 30%. When we had COVID, we saw a number of our folks so tasked with so many hats that they were wearing that they were unable to basically keep up that pediatric or that pet coordinator status. And we'll come back and hit that hard again. Weighing in kilograms, that's another thing that we want our hospitals to do. Why do you think that's important? Why do we care that the hospital weighs in kilograms?
Weight-based meds.
Weight-based meds. You are correct. So now I'm going to apply this to you. Why would kilograms be important to you, and how do you figure out kilograms as EMS providers?
Divide your pounds by 2.2.
Pounds by 2.2, or what else?
Braslo tape.
Yep, you can use your length-based tape, Braslo tape. I know some of the you folks may be using the hand heavy as well. Get that Braslo tape out and use it. At least you have an estimate. Do you know how the Braslo tape actually works, or how it came about? I'll give you a little bit of a history on the Braslo tape. So James Braslo from North Carolina was a pediatric doctor, but he couldn't keep everything the medications and the things that we're giving kids, and how many joules and whatever we're shocking. So they used a national survey. It's I got to think of it offhand, and it's not going to come to me right away, but it's where they weigh the kids, they figure out how tall they are, they do all of this whole process, and it's been repeated a number of times because we're a nation of comorbidities, and with that obesity. And those kids fall into an estimate, and then they fall into the color range. This isn't something that a hospital would use. So a hospital would use a Braslo tape. We'll just say with the Braslo tape for right now. They get a kid that's transferred to them. They use the Braslo tape emergently. So they use it emergently. It gives them an estimate of where this child is going to fall, unless they're 3, 4, or 5 kilograms, of where this child is going to fall, and how much epi do I need to give them? What size tube do I need to put in them? How many joules am I going to shock them at? All of those things happen. But once they get that kid stabilized, once they stabilize them, then that's where they're going to go to the kilograms. They're going to actually weigh that kid either by the bed or some other method, and then they're going to get the appropriate milligrams per kilogram is what they're going to do. And then the other part of it is our ED disaster plans. We want to make sure that we have disaster plans out there, and that everybody knows where to go, knows what to do in the event of a disaster. And a disaster is not a matter of if, it's a matter of when those disasters are coming our way. So that's basically my performance measures for the emergency departments. And it looks easier than it's done. The readiness program for pediatrics and the recognition program with EDs, I struggle with that just a little bit. And the reason I struggle, and I'll be very honest with you, is applications for recognition, I think, need to be very inclusive of a lot of things. And we need to know the good things that people are doing out there, but we don't get to hear everything that the folks are doing out there as well. So my performance measures for my pre-hospital folks, those pre-hospital measures come again, and it's Pediatric Readiness Recognition Program. With the recognition program right now for pediatric recognition, we have 6 of our services in the state of South Dakota that are PEDS recognized. So they're PEDS ready. We took the program, we piloted. Nicole was one of those that we piloted with a number. I think in 2019 we piloted it, and I pulled it, and I pulled it for a number of reasons. But the reason I actually pulled it was we weren't getting a good enough smattering with it, and it was so lengthy. I simplified it, and I want it to be simplified. So we went from like 30 some pages of information that you needed to fill out and to get signatures here and all of this stuff that you had to jump through the hoops. And you folks are already doing this. So being the fact that you folks are already doing the things that need to be done, I don't need to ask how many people are on your ambulance service. I don't need to ask how many calls you run. I don't need to ask if you have the right equipment. That's the stuff the state already does. So it's a matter of checking the blank and going from there. The other thing is that I am really big on, and our whole program is really super based on pediatric emergency care coordinator. I call EMS our pediatric champions. In the state of South Dakota, about 85% of our ambulance services have a primary pediatric champion. And then we have alternate pediatric champions as well. Why do you think we have alternates, or why do you think we ask for alternates?
Because the primaries aren't always available, and we rotate a lot of things.
We do. So, and we can have more than one. So we can have more than one alternate, but we try to send the note or the letter or whatever we're doing, we try to send it to the primary, and then we use the secondary. So we use our alternate, but we can have more than one alternate. I've got a service in Oneida. Just had a great conversation with them yesterday, and they're getting ready to work on a program, but they're going to need extra help. And having an extra pediatric champion is going to be a fantastic way that they're going to be able to get some extra things out there. Let me get here. Knowing your disaster plan. And then they're talking about use of pediatric specific equipment. In the past, we've had surveys. We put surveys out there, and I'm sorry, folks, it is what it is. If you don't collect data and don't have the research, you're not going to know what where you actually are standing. But those surveys for a number of years were, do you have a pediatric champion or a PEC, or do you have, and are you using your pediatric specific equipment, and can Lynn perform and use that piece of pediatric equipment efficiently? Can Paula do the same thing? Can Elizabeth do the same thing as well? And then we're looking at disaster plans. So there was a big focus on that. I'm going to give you a heads up. In 2024, May of 2024, we're going to have a big survey coming up. And with that big survey that's coming up, it's the pre-hospital readiness survey. And hopefully my goal is basically to start getting you folks prepared for that so that you're successful. Years past, we've always had 100% participation in the survey from our EMS agencies. The last time we did a big survey for EMS agencies was in 2013, 2014, had 100% participation. When we did a large survey, so it's a very in-depth survey with the EDs, was it 2013, 2014 again. And in the state of South Dakota, we had 98% of our hospitals that actually participated in that. It doesn't come without work, folks. And I don't mind the extra work. Preferably if you get an email from us and you either have questions, give me a call, or get the survey filled out as quickly as you possibly can, because I know how busy we all are. And then you're going to get a phone call from me. And the phone calls are a good thing. And the reason the phone calls are a good thing is that we get an opportunity to connect with you folks, to figure out what your needs are, just to see how you're doing in general. What's happening within your ambulance service? Have you lost the number of ambulance or folks as far as your providers? Have you had retirees and things like that? Have you had new people? Have you had exciting calls? Have you had really bad calls? We want to know about those things. I'm going to look at our chats here. DOT. Yes, thank you. Okay. And then the other part that we have with that, again, is the disaster plan. We did a presentation on a disaster plan, I think last year sometime. We had emergency management from Sisseton, we had emergency management from Lincoln County, and we had emergency management from Pine Ridge. You would have thought all these guys were scripted. They did an amazing job about talking about emergency management, not only in our counties, but on the reservation and how they handle things differently on the reservation, which was very, very interesting. The thing that you folks need to know about your disaster plan is the disaster plan starts, where it starts with you is triage. Triage, recognizing that you have a disaster on your hands. If you are being overwhelmed and you're having to call extra services in, that's when you call your emergency manager. You call your emergency manager and he's going to get everything started for you. Do you have an actual disaster plan in your hands? Nope, you're not going to have that on the EMS side of that. That basically goes up to the state level, but your emergency manager is the person you're going to contact, and he's going to help you facilitate that disaster plan and move forward as you take care of the your number of patients that are in a potential disaster. Family advocacy and our advisory committee. With our family advocacy, Mike Turner is our family advocate right now. And with Mike being our advocate at this time, Mike's incredible. If a number of you folks know me, I crash into people. It's not that I call it crashing into people, I think, after the movie Crash. It's not that I planned for something to happen. I think sometimes it's divine intervention. And a number of years ago, Mike Turner, I happened to be shopping in Costco, and he had his family with him, and this cute little blonde-eyed, blue-eyed little guy in a wheelchair, reaching out for me, nonverbal, and biggest smile on his face, interacted with him. And then I went on my business, and I went halfway down the aisle in Costco. And when I got halfway down the aisle, I turned back around, looked to see if I had a card. And I actually had one, and we kind of started talking about children with special health care needs and whatnot. I gave them my card. I didn't hear from anybody for 3 months. His wife, Elena, reached out. Lo and behold, she was the executive director for the American Academy of Pediatrics chapter here in South Dakota. She's done a number of other things. And then consequently, after that, our pediatric family advocate, or FAN, retired. And as she retired, we get a new person at the university, and they're talking to me about all my grants and stuff. So I'm running probably between 6 and 7 grants right now, and called me and said, hey, you have the most number of grants in the University of South Dakota, blah, 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 blah. He's telling me what his name is. And I never associated. I said, how do you know so much about me? And it was Mike Turner, who is Owen's father. And then we ended up working it out where he was able to be our family advocate. He has done some amazing things for our state. Our advisory committee, we have 8 core folks that we have to have on our advisory committee. Right now, our chair is Dr. Waldner from Redfield. I suspect Dr. Waldner is very, very busy with the loss of Dr. Owens, and I'm going to miss Dr. Owens terribly. He had me on speed dial, and I had him on speed dial, and there was a lot of things that we went back and forth, and he was big on disaster preparedness, and he brought EMS for Children into the program for Disaster Training Day in 2015, and we've been there ever since. So if you don't know what Disaster Training Day is, we go down to Vermilion. We have all disciplines of students that are in the USD's program. So it might be dental assistant, it might be nursing, it might be med school, it might be PAs, it might be pharmacy. there's just a number of folks. We go through 400 folks. But what Dr. Owens allowed me to do is he allowed me to take the pediatric perspective of disaster preparedness in there, because we think about adults, we focus on adults, and we forget about kids. So we go through 400 kids. That's coming up in February 15th for us, and then we just kind of keep moving through the state. So it's some really cool things, and I do miss him terribly already. Again, we talked about surveys and assessments. A survey May 2024. Why do you think surveys are important? Why do we survey? Why do we do an assessment? We have
It can be used to apply for other grants.
yep, part of that, yep. So we have survey fatigue. We truly honestly do. There's a lot of survey fatigue, but it's collecting data. Data is important to me, don't get me wrong. More so than data for me, I'll get the data collected. I'll do my performance measures and everything that I need. More so, our office is more focused on what do you folks need. A number is a number is a number. You need a number basically to figure out where you're actually sitting. So you can't measure something and improve it if you don't measure where you actually are with it. So that's one of the things to keep in mind. So how do you know if an agency or if your agency is prepared to care for kids in the event of an emergency? You can scan that QR code. Where that is going to take you is it's going to take you to the EIIC, which is the EMS for Children Innovation Center. And there's going to be a National Pediatric Readiness Toolkit for our pre-hospital providers out there. The toolkit is kind of a checkoff list of the things that you can start working on now as we get prepared for the survey in 2024 of May 2024. And then at some point in time, they'll release, they're actually testing it right now with a couple of states. I think Michigan is one, and I think there's another state that is testing the survey. And when that survey comes out, you'll be able to have a hard copy in your hand and then go from there. It's not going to be apples to apples. So when we look at 2014 and now we look at 2024, there's a lot of things that have changed. So the survey is not going to be apples to apples of a comparison. So we're basically going to start you as a trend at a baseline trend. So if it's on a score basis. So your scoring is 100% or 100 is what your score level is. The higher your score is, the better chances that you have children who are going to survive. The lower mortality rate is basically where we're going with that, or what I'm trying to say. We definitely see it in the EDs as well. And we'll be sending the demo copies and stuff coming up as we move forward. Let me go from here. High pediatric readiness, again, scores make a difference. It also makes a difference in our ambulance services as well. So pediatric education, when we talk about pediatric education, how many of you have participated in any of our pediatric education? So we're involved with a number of different groups. We're involved with the Heartland EMS for Children. So back in 2020, everybody kind of lost it, and we didn't have any way to communicate and get folks the education that they needed. The first virtual education that we did as a coalition for Heartland EMSC, or we like to call ourselves HEC, is we did human trafficking. Did we do one night or 2 nights? We did a couple of nights of human trafficking, covered 6 states, and we had over 2,000 providers that popped on to learn more about human trafficking. We always try to include human trafficking every year, once a year, so that you folks are better adept to identifying it and getting a good idea. We have a YouTube channel. Our YouTube channel for the Heartland EMSC Coalition is that Heartland EMS for Children, and it's the coalition. And you type that in, and there's a number of resources that are available. So we've videotaped and have archived those educational events. We don't archive those events that are graphically graphic sensitive nature. So we're not going to do human trafficking because it gets very, very graphic and the language gets very rough, and it's rough and tumble. We didn't do, we did a training with the Sandy Hook. We didn't record that. So there's a number of folks that's up to them if they want to record or not to have it recorded and then to have it archived. We also worked with Midwest EMSC. So we had a Midwest EMSC Foundation. So the 6 of us went and joined up with the Midwest, and we have 11 or 12 of us as providers or EMSC program managers that put on a educational event in November 2nd and then November 9th. One was for EMS, one was for the EDs. We had folks that were speaking from Harvard. We had folks that were speaking from Ohio on disaster preparedness. These are experts in their field. Absolutely amazing training that we had out there. So if you're looking for training, I'm sorry, I can't give you credits for it, but if it's something that you want to know a little bit more about, take a look at it. It's Midwest EMSC. That's on the YouTube channel there. Heck, I'm thinking we've probably trained over, as a coalition, we've probably trained over 4,000 or 5,000 people. I know that doesn't sound like a lot across the, when you're looking across 6 states, but it's something to start with, and it's good education. We have ANCC hours that are attached to that. So that means not only is it for nursing, it's for physicians, it's for PAs, it's for social workers. They all get credits for it, as well as our EMS providers as well. And then we did the same thing with Midwest EMSC. That we did at a level 4 when it was the hospital-based one. You got CEs for that through the ANCC, or we did it through the state level for your credits there. Pediatric champions. Are most of you who are on right now, are you a pediatric champion, or do you know of a pediatric champion?
Yes.
Okay. I think our pediatric champions it all starts with you. We can't do it with the pediatric champions. Again, we're an office of 2. You're an extension of the things that we do and the things that we want to put out there. And without you, we actually honestly can't do it. I hate this. Oops, sorry. I had a QR code on there, and maybe it'll show up a little bit later, but there's a QR code where you can actually go to our website. If you want to become a pediatric champion, you'll go into sdemsc.org, and with sdemsc.org, you'll go up into the pediatric readiness, and the first tab that falls down is EMS law enforcement. And then you go in and there's an application for pediatric, to become a pediatric champion. A pediatric champion is a number of things. You're already pediatric champions just by virtue of, one, that you're attending here tonight, but a pediatric champion doesn't necessarily have to be a title, but it's somebody who's making sure that we're getting education out there. It's pediatric education. Maybe you're the person who is getting the supplies and replacing the supplies. Maybe you're the person who's going to the school and maybe you're putting on a poison presentation for the kids. Maybe you're doing, I know Nicole and I worked together a number of years ago, and we worked on the disaster plan for the state of South Dakota. There's a number of things that you can do. Again, we're not limited to the number of alternate pediatric champions. We just need somebody that we can contact, and to make sure that there's a secondary contact or a third contact that we have out there so that your services is able to take advantage of the programs that we have available for you. So it really, truly, honestly starts with the pediatric champions, our ears and eyes. Again, 85%, we have 35% of our EMS agencies have an alternate pediatric champion. And again, go to sdemsc.org if you have an interest in that. We talked about the Pediatric Readiness Program just a little bit. The Pediatric Readiness Recognition Program. Elizabeth, you just happened to be on tonight, and she was one of the 6 that received the award. Again, coincidentally, there are 6 criteria for the recognition program, and it's a simple form to fill out. Nicole, would you agree or would you not disagree? Or Elizabeth, either of you?
Yes, I would agree, and it's well worth it.
It is well worth it. There's a lot of,
Same.
go ahead. I interrupted someone. I apologize.
It was just me, Elizabeth, just agreeing that yes, it is worth it and valuable to have. So
I think it's very valuable to have, not only that you have a plaque on your wall and that you can say that you are PEDS ready. You're doing a little bit of a checklist, you're doing some community outreach and things, but it's also something that you can take back to your community and let the folks know in your community. So maybe it's your council, maybe it's your president of an association or the South Dakota Ambulance Association or any of those folks. Let them know that you are participating and that PEDS are a focus of yours. However you handle it is how you handle it. And this plaque does not give justice to the recognition plaque out there. It is absolutely beautiful, and it's 3D and it's incredible. Just to kind of give you a heads up, so I'm kind of selling it on that way. When we look at the 6 criteria, the criteria are pretty easy. You comply with state EMS statutes and regulations. So we look at the Office of EMS. They're asking you to do a patient care report. You put your patient care report in, you're taking care of it, you're staying updated on the new programs that maybe Image Trend is working through and whatnot, but you're actually submitting your information to them. Again, it's NEMSIS compliant is basically where you are. You participate in South Dakota EMS for surveys, for children's surveys. The surveys, I understand, I totally get it. Surveys are, again, we have survey fatigue. They're short and sweet. Most of them have been short and sweet. They've been repetitive. This one, again, is kind of a bigger one that's coming out. I'm anxious to see where we're actually going to be with that. Designating a pediatric champion, that is definitely a criteria that we have. Even to receive some of the resources that we have, you have to be a pediatric champion or have an alternate pediatric champion actually apply for something if you are looking at, participating in any of the programs or anything. We really kind of make it a mandatory thing, or we really encourage you to be a pediatric champion. We have pediatric champions in law enforcement. We have pediatric champions in school nursing. We have pediatric champions in non-transport fire and rescue. I think, Patty, you guys are non-transport fire rescue up there. And we're working on pediatric champions in a lot of different ways. But our primary focus right now is our pediatric champions and feeding. I compared it to somebody the other day because I know the sourdough starter. So I've got sourdough starter. You guys are my pediatric champions. And if I don't feed you, I'm going to lose you. So I need to feed you to basically turn you into something good. So we've got a lot of great things that are kind of planned, and you're going to have to hang tight for that in a little bit. Community outreach is definitely important. We have a number of folks that are doing community outreach. Tell me about the community outreach some of you folks have done. I know somebody, Elizabeth. I know Elizabeth has taken and used our bicycle safety program and has put out bicycle helmets.
Yeah, so we did that kind of in conjunction with, actually we've done it a couple of times. The most recent was a downtown Friday night celebration that our city puts on during the summer. And so we worked with the police department to set up kind of like a bicycle course in the street, the portion of course that had been blocked off. So kids could come down. It was also right in front of the bike shop. So if minor repairs or seat fittings needed to be done, they did that. And then we, along with the police department, did helmet fittings and free helmets. Fantastic. It was amazing.
We did. Oh, sorry.
Oh, go ahead. Go ahead, Nicole.
I was just going to say we did something similar. This was the second or third time we did it also. Well, we do it every summer, but we use the helmets for the second or third time. A bicycle safety during our town celebration in August. And then we hand out helmets and we work with the law enforcement to set up the same thing as a course, and the kids can all do that. And then they get prizes and stuff. And we also go into the school and do some of the CPR CPR stuff there and just different activities with the kids. We did the car seat program. That one you had a couple years ago, we did that at the school too.
Our pediatric champions are doing some amazing things, and it never fails to blow my mind, for lack of better terms. We've got pediatric champions, Burke, South Dakota, during the, oh, heaven forbid, farmer's market. During their farmer's market, they're teaching Stop the Bleed. Kevin Heath and I had a talk. He's from Oneida, and we did the Helmets for the Holidays campaign, where you could order your helmets and where you're going to have a bicycle rodeo or not have a bicycle rodeo. And then what they're planning on doing is, again, they're going to do that. Santa basically lost a box of bicycle helmets, and with that loss of the bicycle helmets, they're going to have the first 24 kids basically that send them a picture of the bike, do an application. They're going to do similar to what Elizabeth and has done, and they're going to check their bikes over. They're going to fit their helmets to them. They're going to, they're considering doing a stop the, not a stop the bleed. They actually, I think they are considering doing a stop the bleed. And then they're also considering CPR, just hands-on only CPR. And then our conversation got a little bit deeper. And then with that conversation, and again, that was my crashing into him, I mentioned something about stop the bleed kits for our driver's education folks. So Kevin as a pediatric champion, and then Brian Ring as a pediatric champion. It just so happened that the application for Kevin's son was sitting on the countertop that he was going to be taking driver's ed. And I said, hey, here's what we have. So we have an impairment program that Jamie has developed. It's called the I Choose program. She's got I Choose and the I Choose To program, which is very, very active program. And then we have a seatbelt program as well. And then we also do true choices, chances, and decisions. We can't make it everywhere, but if you have a the time and the ability to get into a school system or to get into a driver's ed program and actually do a presentation and do a Stop the Bleed course for them, I'll provide Stop the Bleed kits to the students, I'm going to say, who graduate from that program. I have a limited number of kits, so we'll work on that application kind of as we go, but that's where I'm foreseeing that this is going to actually go in the near future. So we want to make sure that and the reason we're doing that, I can give you the reason why we're doing that. The our whole goal is to have safer roads and safer cars, safer drivers, safer speed limits, and then the other is post-crash care. We looked at post-crash care, where could we do our best with post-crash care as EMS for children, and we felt that our young drivers are more apt to have an accident, and we know that that's true, are more apt to have an accident or come up on an accident if they're with their friends and stuff, and at least have the knowledge to stop the bleed, and then have some equipment, basic stop the bleed kit to actually get something started before help arrives to them. So that was big for us to be able to do that as well. The other thing was pediatric equipment. We've got pediatric equipment. You have those already per your national recommendations, and that's going back again to the application for the Pediatric Readiness Recognition Program. You'll find that right on SDEMSC. And if you go back into pre-hospital or wherever it happens to be, right underneath it, there is the application. Put the application in, and we go from there. Safe transport devices. The other thing is safe transport devices. You don't have to go out and buy a safe transport device. We actually have additional funding, and we'll be receiving, I think, 50 additional safe transport devices. And it's just a matter of making sure that you are a pediatric champion. We make sure that you get the education. We pretty well don't put anything out there unless you have education on it, and that you're using it in your unit. We don't have state laws. Well, I'll take that back a little bit. We don't have a state law, or we don't have a protocol in our EMS protocols that says you have to secure a pediatric patient in the back of your ambulance using a device. But what we do as EMS for children, we have guidelines for you folks basically to follow. And right now, I understand, and I get it, there's not the criteria. So the jump seat that you have that you can pull down and put a kid into a semi seatbelt. That's not the way you're going to transport a child who's sick or injured. You're going to put them on your bed, but this device that we have is a universal device. It fits children 5 to I think 110 pounds. So it's very universal, easy to put on. Jamie does a fantastic job of educating on that as well. So we want to make sure that you folks have them. And then again, disaster preparedness and learning more about disaster preparedness and how that actually works within your facility. So that's a pediatric readiness recognition program. I'm hoping that we can grow that. I'd love to grow it. Part of my performance measures that I didn't share with you is that we have to meet a certain percent by 2027. It may be 50%, it may be 75%, it may be 25%, depending on how difficult the tasks are. I would like to, by the end of 2024, I'd love to see our services have at least, I'll go for 15%. I'd prefer 20%. There's no reason that, for me, I guess I don't see any barriers for that you should not take the opportunity to apply for the Pediatric Readiness Recognition Award and or become a pediatric champion. We did a boot camp last fall. We did it at the conference. Everybody received an invitation. Most of them were our pediatric champions, and with those pediatric champions, we had 17 services that attended. With those 17 services that attended, we did a 4-hour boot camp, hot and heavy. So we did, what is EMSC all about? We did case studies, and then with our case studies, then we broke out into groups, and we either did a skills training, or how do you take skills back to your service and train your folks for the skills that they need. If you look in the left-hand corner, the blonde that's smiling with the curly hair, that's Lynn Thomas. She was very instrumental in assisting us with that. She's going to jump back on board and help us with some programs. Chetty behind her, she's got her eyes closed. Chetty did the Carter Kit training. She's amazing at it, and we'll probably have her do additional training coming up in once we get our sessions together. She is a mom of a child who is on the autism spectrum disorder. If you look at the young lady down on the left-hand corner that's sitting, that's Jamie Bartell. Jamie is my right-hand gal. If you look over in the right-hand corner is myself, and then one over is Reagan. She is our Master's of Public Health intern. She actually did her APE project with us, and now she is moving on with her capstone project with us as well. So we had a really amazing group of folks that jumped in and helped. And of course, we Jamie Jamie Zilverberg from the Department of Health, the state trauma manager, was there as well and supported us. And we had a lot of fun. There were a lot of prizes that were given out. I'm not sure if everyone went home with a prize, but I'm pretty sure that it was pretty close to it. Most everybody was pre-registered. We had a few, I think we had 6 or 7 folks that walked in afterwards. If you look, so Jamie and Lynn and there's Diana Spinner, Elizabeth has a part of that. So you got a 3/4 zip. Elizabeth, she went through the whole gamut of it. She ended up applying for her pediatric recognition. She also received a certificate that she is a pediatric champion. I had a gal run me down while we were at the conference, and she said, well, where's my 3/4 zip? Where's my shirt? And I'm like, you're not attending a class. The shirts don't go out for free. Any of you that have not received your certificate and you've not received your shirt, apologies to you. We had, if you know that there's shortage of paper, there's shortage of ink, and then we had to have the frames. We do have we want to send it all out at one time, so it'll be coming. Don't sweat it. And we'll probably do another boot camp next year, and then we're going to actually move forward with the boot camp and then additional education. Pediatric specific resources and programs. We have also within our EMSC program, we have a safety and injury prevention. I think we're one of the few states, if any of the folks that are doing the things that we're doing, we have the impaired driving, and these fall through the Office of Highway Safety or the Department of Public Safety. We do the impaired driving, we do bicycle safety, we do occupant restraint. Under that falls the buckle up, phone down. We actually were a test site. There were only 2 test sites across the state, United States, Jackson, Mississippi, and then Sioux Falls, South Dakota. And they actually came in and they gathered pre-data and post-data on the number of people who were wearing their seatbelts and who were on the phone. It was a challenge, and it was a big something to get up and going in 6 months, to include a website to get people to participate, et cetera, et cetera. And what we're doing right now is we're just kind of leveling up with the Buckle Up, Phone Down campaign. We're keeping it for the Department of Public Safety, and we have it, and we're going to maintain it for this year. And then the goal is to make it a statewide program. And as it becomes a statewide program, then the Office of Highway Safety will take it over. And then with the Stop the Bleed, I kind of mentioned to you folks as well, if you have a driver's ed course within your community, and the goal that we're working for is train the trainer programs. So there'll be a train the trainer program for our pediatric champions, ED, EMS, and we'll get you trained up with a canned courses, if you will, again, with that occupant restraint, the impaired driving, and then want to ensure that you're Stop the Bleed certified. And with that Stop the Bleed certification, then you will have the opportunity to teach those driver's ed students, and it's specific to driver's ed students because that's how I wrote the grant. And then those Stop the Bleed kits can go home with those kids. So a number of really interesting things and cool things that we have going on. Let's see what else I have. The reason we do this, part of the reason that we do this is we have 12. So we have 12 grandchildren. A number of them are not there. There's 4 of them that are not with us in Michigan. One little, the youngest was a brand new baby, and then the other one was a 2-year-old that was at home, and he was vomiting in the whole 9 yards. Again, I have a number of grants, kind of going back to talking with that. I have grants from the Department of Public Safety. We have grants from the Hospital Preparedness Group. I'm super proud to let you folks know that the last 3 Broslow carts for the emergency departments are in the hospitals that needed those Broslow carts. And we're getting additional equipment for them. We're actually going to ramp up the Carter kits again. Carter kits are going to be for EMS. We're going to focus on school nurses, and then we're going to focus on our law enforcement as well. I think I said that. Don't think I said it backwards. Anyway, we'll focus on those folks as well. And then we have non-transport. So non-transport fire rescue, pediatric bags. So it'll be a BLS bag, but I've kind of had some really great conversations with a number of folks, and it may be just a Stop the Bleed kit for maybe a police officer, or a smaller kit for a police officer that needs it, that comes across a pediatric person, and then maybe it's a smaller kit. Maybe it's not that, I'm trying to think of, there's a service up by Elkton, I can't remember what the service was, that came. They are non-transport fire. They have to wait till Elkton gets there. They have to wait till Marshall gets there, and they didn't have any equipment to stabilize a kid. So while they're no equipment, we provided a bag, and it had everything from, well, it was $500 to $600 bag. It was just stock full, and you had to carry other things home in your arms as well. And we did a quick training on that, and we did that during fire school, and that was it was just called bag check. And we took everything out of the bag. How do you use it? What do you do with it? When do you use it? And where do you find your supplies? Even though we give you equipment, or we provide resources, or we provide a number of things for you, it becomes yours to maintain after that. We do our best. We've helped out. So Lake Norden, a number of you folks know that Lake Norden lost their emergency services to the fire. We were able to provide them with a pediatric bag to get them up and going, and to ensure that they were up and rolling. And then they came back afterwards and said, hey, do you have a list? Where can we find this, the same equipment? Because they wanted to set both their trucks up the same. So just to kind of give you an idea of, the things that we were actually doing out there on this side of things. The future. So what does the future look like? What do you want the future to look like? I'll ask that question. What do you think the future of EMS for children should be for our pediatric champions, for our communities, for our kids? What do you think it should be? I'm open to ideas. What do you want it to look like?
I think the driving program and texting is great. All too often when we think of peds, we think of the little peds and not the older peds. So definitely more things that involve them. West River and a little bit moving towards Central, we have a thing called Freshman Impact that takes place. It's another group that puts that on, and then usually the fire department, the highway patrol, us as EMS all get involved. We get stations. They do a mock crash. They do like a trial afterwards. So it's really involved. In fact, I'm thinking that that might be a good place to do like a stop the bleed at our station this year. But definitely something that involves kind of the older end of those pediatrics would be great.
Yep, those kids that are driving, and we're looking at post-prom and the freshman impact, and doing a stop the bleed course I think would be a great thing with those. And those are conversations that I've had with a number of folks over the last couple of days. Our goal is to basically put out education, and I kind of blew this by a couple of folks that out there just recently in the last couple of days. My goal is to kind of put I don't know if you folks are familiar with the echo training. So echo training is basically you have somebody that is at, let's say, a paramedic, because I know one of the things that we learned from our boot camp is we want peer-to-peer training, not necessarily that we have training from a professor that's talking way above our heads. We want someone who speaks to it as a BLS level, an ALS level, that we're learning something, more case studies, breaking up into groups, and then we break up into a group, and then we come back and we talk about the things that we need. My goal is to put out a series of 6 to 8, like back to back. It's going to be hot and heavy with the education. Get it done before the summer so that you folks can enjoy your summer. Not to have something that is going to impede with your holidays and hunting. We can't forget about hunting or fishing. Farming, we got to think about that as well. So, we have a number of those things. So maybe that January, February, March timeframe, even though we're doing refreshers, maybe we'll have something in there. Community partnerships and outreach, really reaching out to those communities and giving you ideas of how you can reach those. So National Poison Prevention Week is coming up. With National Poison Prevention Week, we do, so this will put me in the Sanford world, right? So I do Sanford poison as well. It puts me in the Sanford world, and then where that comes from is we have a coloring contest. So we have a coloring contest for, I believe it's our first graders, and it's so much fun. Jamie's got a really cool coloring page that's available for these kids, or that will be available for these kids. The school teacher, she sends it back in, they color it. These kids are so incredibly creative. It's just absolutely amazing. Then we actually judge the coloring page, or the coloring pages that we receive back. It's an absolute riot. We get together with our pharmacy folks over at Sanford, and a number of folks we kind of invite in to come to judge the contest. And we put out $20 gift certificates. And last year, Burke, South Dakota had 100% participation. Tammy Hotz and Mark Green. So Tammy is from Burke County Community Hospital, and Mark Green is my pediatric champion and also the police officer. And I asked him, hey guys, would you do me a favor? Will you do a pizza party for this school that won the pizza party? And then we supplied the pizza, we supplied the soda, and then they did education with those kids. We have a number of resources available for that as well, just to kind of give you an idea. Everything, you don't see everything on sdpoison.org, but if you give us a call and let us know what you're doing, or if you want to go in and you want to do some education with first and second graders, Jamie is seeing an incredible amount of folks that are out there. These young kids are out there, and they're, man, the things that they tell her, but where they're experimenting with their drugs, be it marijuana, be it if they're pill popping or whatever the case may be, they're doing it in the school system. And the reason that they're doing it in the school system, why do you think it is?
Access.
Access. So it's a safe place for them. They know that there's going to be somebody to take care of them. So somebody's going to call. That's another thing I'm going to bring forward as well. So Jamie is also on T Fire Department, and with T Fire Department, she was struggling to get Narcan available so that they could carry it with their fire service, because they do not have an ambulance service, although they do have PD that responds with them as well. If you are wanting Narcan on a non-transport fire, and I'm not sure how many of you may be non-transport fire, reach out to Bob Hardrick. Bob will get you the paperwork that you need, and then it shouldn't be too much longer than you can get your Narcan on board. Anybody have any questions for me? So again, we're trying to come up with some train the trainer courses for our pediatric champions to arm you and to really develop your, not only your skills, but your confidence to go out there and interact and make a difference in your community and lift up your community and get to know your kids. Who are your special needs kids? What do they need prior to? So it's kind of a meet and greet. There's all kinds of programs that you folks are coming up with. I mean, they're just brilliant programs that are coming up, and we absolutely love it. I'm gonna check the chat really quick, like.
Corolla, this is Nicole. Can you and I connect sometime, because we are hosting the Freshman Impact here in Berlin Armor, and I'm wondering if we can come up with something as far as the vaping and the poison and those kinds of things.
Absolutely. So in part of Jamie's impairment, she does cover marijuana. A lot of the impairment grant is focused on alcohol, but when we look at all of the poisons and stuff that are out there, it is impairment, and she's got a really, really good program that's out there. I'll probably put you into contact with her, but we can work together on the Freshman Impact and kind of discuss that further. Somebody said something about the real dangers of exposure to marijuana exposure. I think that's really super important to come up with a program, or to even have a learning a course that we actually put out there where we actually teach you about the dangers. Marijuana toxicity is a real thing. I don't know that, everybody kind of thinks that, people get high and, they're eating pizza and maybe they get a little bit of anxiety and stuff, but marijuana toxicity is very, very real. I will tell you also that ivermectin toxicity is a real thing as well. I damn near killed my cat. Cats, if you will. I overdosed them, and oh my gosh, I thought they had rabies. It was horrible. Chris Escott, thanks Chris for jumping online. The dangers of online dating apps, talking to strangers, and online bullying. I think those are things that we need to pay attention to as well. My grandkids, and I'm not sure how many of you have kids, how many of you have grandkids and whatnot. YouTube, TikTok, all of those social media places that these kids are going, they truly honestly think that it's the truth. I remember when my kids went to kindergarten and Mrs. So-and-so basically said, you need to do this, and you come home and your child says, well, Mrs. So-and-so said I can't do this. And it's like, whoa, 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 I'm your mom. This is the way that this goes. It's just kind of interesting how they're influenced, and we want to make sure that they're getting the right influence rather than the wrong influence. Again, when we look at the dangers of online dating and online dating apps and things like that, the human trafficking, I just spoke with one of my colleagues in New Mexico, and her grandson was he got off the bus. He was walking home. He was walking home with an older young gal. A white van pulled up, and basically their whole intent was to take her grandson. He ran to the house as quickly as he possibly could, got himself inside, and the little gal stood her ground. But that's exactly what they're doing in New Mexico, is they are taking vans and they're stealing kids, and you're not going to see them. And they're in this horrible world that they're in. It's a super sad thing that's happening. But again, I don't have anything else for you. If you have questions, please feel free to reach out. And I'm gonna hang around. I'll be happy to answer any questions or any thoughts that you guys might have. I hope you have a better understanding of what EMS for Children is and the resources that we have. I do my best to write grants that I know that are needed. If there are resources that are needed and you see a need and I can figure out a way to get money for it, I'll figure out a way to get money for it. I just need your help in making sure that the resources that I'm asking for or distributing are getting from point A to point B.
Thank you, Corolla.
Yeah, thank you.
Hi, yep.
Well, thank you, Corolla, for that. I will leave the Zoom open for a couple minutes. If anyone has any questions, you should be getting your continuing ed in the next day or so. And you should be receiving an email too for a post survey as well. We appreciate you guys all jumping on tonight and have a good night.
And I
Thank you,
apologize.
Michaela, and thank you, Corolla.
You're more than welcome. I apologize for the technical errors on my part.